I have marked a little bit the landmarks, okay? The fibula, more or less the shape of the calcaneal. Remember that goes in this direction. Usually, even in flatfoot, we tend to make the incision and believe that the calcaneonavicular joint is down that it is, in fact, so it's good to make all the draw. This is the sinus tarsi, this circle here. This is the peroneal tendon. I think that all the models have peroneal tendons, so take care. And this is the calcaneocuboid joint, okay? I'm going to make the demonstration with this incision, okay? An incision that runs parallel to the peroneal tendons, okay? Because have some advantage, maybe some disadvantage, but the more important reason is because if we want to do another incision in here, in the calcaneal, we have a space of security, okay? So let's go with incision. The idea is to run from the more proximal part of the sinus tarsi, here, okay, in this red point, to the down part of the calcaneocuboid joint. This way you have control of where the posterior facet of the subtalar joint is and where your joint is, okay? And you can see even the ligament in the real cases, okay? So let's go then. Okay. Okay. I'm going to need something to separate. So put it here, there. Okay. So you can see then down the skin you have a little bit of tissue. You have to cut it and go deep. And here, I don't know if you can see on the screen, there is like a tissue different. This is the sinus tarsi in this part here. Okay, you will see in the model. So you can take it out like a synovectomy or something like that, just to see well where you are. Here we have all this space of the sinus tarsi. Can you see here? Okay, so now here in the down part, if you dissect a little bit, you are going to find the peroneal tendons, okay, if you want to look for that. But as you dissect with the periosteum, you are going to arrive to the calcaneocuboid joint. I'm going to be a little bit aggressive just to show you where it is. Can you see in the final end a little bit white? Okay, this is the joint. Okay, you can test if you want with the knife to see the direction. Is here. Okay, is this part. Okay, so let's go then with, maybe it's easier here. And the other retractor runs here to protect the peroneal tendons. Like, so this way you have exposed the calcaneocuboid joint here. You have the sinus tarsi, you have the posterior talar joint, you have the peroneal tendons here, and you have all the anterior tuberosity here. So let's go with the saw.
You want to come this side?
Don't be afraid. Maybe.
You said that to me, isn't it? I should be afraid.
Can you?
Can somebody help?
There is.
Can you help?
What do you want me to do? Hold this?
Yes. I don't know.
No,
Maybe-
I can help.
maybe
Yeah.
Okay. Yes. Just to show one thing. Don't worry, because I'm not going to cut now. This is the direction of the joint. So try not to do the osteotomy like that, open, because you are giving the way to go up. Okay. Try to run parallel or a little bit like that. Okay. To make thinner the space in the upper part. Okay. advice
How far
here.
from the joint are you there? How far from the joint?
Oh, how far?
How far
From the calcaneocubital
In
joint.
this case, here we have the sinus tarsi, so I'm in the limit of the sinus tarsi. So here is going to begin the posterior talar facet. Okay, the distance
So that's
between
your
here
landmark.
and here depend of the patient. Okay, this is a little foot. This is a little foot. Okay, the real size of this maybe is a 35 in Europe. 35, I don't know, in England, 10?
Right, yeah, so everything is different.
Okay,
yeah.
right.
So the most important part is the distance between the facets, not the distance from the calcaneocubital joint.
Yeah, the idea is to go far from the calcaneocubital joint as you can, okay, without go to the posterior talar joint facet, okay. This is the idea. It
So that's your
depends-
landmark, the edge here on the
Yeah,
sinus tarsi. Okay.
Yeah, okay, and try to inclinate the cat a little bit from posterior to anterior to not damage the weight and to go in the middle of the middle and anterior facet. This is the idea, 30 degrees, more or less. As we are going to
30
use
degrees from the plane of the calcaneocubital joint or 30 degrees
from
10 degrees from the
From
vertical.
the
So you put it
yeah, for the
vertical.
cortical.
You said you want to be a little bit parallel to the calcaneocubital joint.
Yeah,
when
so
you first
in this plane, parallel, and in this plane, 30 degrees. Okay? Yes? And as we're going to use a wedge that is a trapezium, it's not a wedge, a real wedge, you have to cut both corticals. It's not an Evans, it's a Mosca osteotomy. Okay? Here, my advice is to end the second cortical with the saw. In the real case, maybe it's better with an osteotomy, but here, for the characteristic of the model, I think that is better. If you want to use osteotomy, you have, okay?
Do you want to
But-
show how the osteotomy is done? Sorry.
Yeah.
So this is vertical. So you go 30 degrees like that.
Yes.
And then you don't do that. You go a bit like this. How the calcaneocubital
Yeah.
joint is. So that's the
okay,
direction.
Parallel to the calcaneocubital joint, or a
Yeah.
little bit inclinated,
Can you see that?
more open in the down part, more close in the upper part.
So in
Okay.
30 degrees and a bit like that.
Just,
Do it again. That's vertical.
yes.
So 30 degrees. Then you close it like that.
Here you can see the wedge is a trapezium, it's not completely a wedge, so you need to cut both corticals, okay? Then, hinterland distractor. If you don't have a hinterland distractor, don't try it, okay? I think that is very, very important, okay? Buy it or ask for AMES to have one or whatever, but it's very important, in my opinion. So, another trick, to put the device, if you put the device right here, you are not going to see anymore, okay? You are not being able to put the wedge seeing what you are doing. So my advice is to put the device in this part, in the down part, and a little bit inclinated. It has another good thing, that as you are making the distraction in the down part, that is where is all the restriction, because it's the ligament, is the fascia, okay? It is better because you have to make more strength in the down part than in the upper part. So we have these two, I don't know in English, these two benefits. Benefits.
Yeah.
Okay.
Yeah. So sometimes you find if you put the hinterland up here, this doesn't distract at all.
Yeah.
I had that before. So it was not any complete ostomy. So
This is a good
it's
trick.
very nice trick that one, yeah.
Okay.
And also try not to go through the tailor head with the KY, because otherwise it's not going to distract.
Yeah.
You're going to cause problems there with the tailor head. So I take an X-ray, an AP,
Let me
just to see. It's an important thing because you know most people just put the KYs and start distracting. But if it's in the tailor head, basically you're destroying the tailor head cancellous bone.
This, yes. It's here. Okay. And now.
Show us how you put your K1s to stabilize the calcaneocubital.
Yeah, okay, yeah. So
You will end.
I would have done now the K-wise before. That's me on the calcaneocupoid joint and going a centimeter into the distal part of the calcaneus and check on AP and lateral.
Okay. Second. So we have our Hintermann in position, and as you see, we have all the surgical field open to put whatever we want in here without problems of vision. And then when you distract, you can see that it's open gently. So in this moment, you are going to measure. But what size?
Can I just say, Danny, can I say one of my, I was shown, keep that Hintermann down, okay, because it can come up. And what I always do, I've seen your pictures, I always bend those K-wires because it will come up and then they cut out. So I think what we do as pediatric orthopedics, we're more aggressive than adult surgeons when it comes to the destruction, because we normally put big, like normally when we take a crest graft, normally we measure like 1.5 centimeters because no, it's going to collapse. And then we do a lot of destruction, then the K-wires can get bent.
Okay.
So bear in mind, just bend them. I'm not going to bend them now, but you can bend them and then push it down. I always push it down and I ask the fellow to bend this.
So okay. So now we have to choose the size of the wedge. Okay. One important thing is that the wedge need to correct a deformity. How to see the deformity correction? Let me just show it. You are going to control this clinically. So in this patient, okay, you can see there is a little bit of abduction here, okay, of abduction. So you are going to try to put in line the anterior tibial crest with the second metatarsal, okay? There is not a huge deformity here, but just to see the effect and how to control that. You put your Hintermann and you begin to do that, okay? Can you see the correction? Okay, I put it, okay. Okay, this is the idea.
Do you ever use X-ray to guide you at this point? Because Moscow uses X-ray to...
First clinical, in my case, first clinical, and when I'm happy because I'm seeing that the abduction is corrected, if you have that, go and make an X-ray, okay?
Do you ever do it gradually? If it's very stiff, like you do a bit, you wait and you do a bit more, and that's what I do anyway. Do you do that or you just go?
No, I try to make several tries, okay, to release the tissues, and when I have all the tissues released, I'm going for the final correction. That, in this case, for example, it will be good for me, okay? So in this case, you have a gap here. This gap is what you need to fill, okay? So you have several trials, and you say this. You go to an X-ray if you want, and say, yes, this is my size, okay? In this moment, you take it out, and you can put your wedge. You can see because you have, okay? So now, when you are going to put the wedge, my advice is that you have the enough gap to put it easily, not need to make like that, okay? So open big, put the wedge with a mosquito clamp or whatever instrument. You put something here. Can you in this gap that have to avoid that the weights come back, and then take it out. You can check here if it's
don't leave it too high up.
If it's in good position, okay, and if it's in good position, you take it out, and you will see that now the wedge is in position, and even here there is a model that is not normal tissue. If you try to move this wedge, it's not easy. You will see, because you can see, but it's not making a strength. Yeah, it's very, if you need to move, you have to open it back and move, okay? And that's all here in the...
Do you ever use the impactor? Do you ever feel the need to use the impactor?
You have an impactor here, but as I said, if you can avoid the use of this, I think that is better.
Okay.
If you open big your osteotomy with a Hinterman, you are going to put it gently, and if not necessary to use a hammer. Okay? I like hammers, but patient no. Okay?
So I use the impactor, Fiona,
Yeah.
and it doesn't move.
No, but
doesn't move.
Do you use the same technique that you get your correction, you measure, and then you open with the Hintermans a little bit more just before you put it in?
Yeah.
Do you do that same?
I think when I first started, I was putting big, like the 12, and now I put the 10 just because of this, because I just couldn't move it. Once you put it in, it's just very difficult to move.
Because of that friction coefficient, if you
Yeah.
don't open it out enough, then it's hard to get...
In my experience, if you put a 12, it's just not going to move, even if you have a Hinterman distractor there, because you cannot distract more than 12. It's very difficult. On this stiff, maybe you can, but...
If you impact, you can move the wedge, but you are going to create a... no?
That's a nice aim to say that you're going to put it without using the impactor,
Yeah.
unless you've selected the wrong implant.
Yeah.
I think that's a good tip.
There are surgeons that prefer to impact, and
like how-
even then ask for a
Metal impact.
for a metal impactor. Okay, it doesn't matter. But I think that is not necessary.
That's usually hip surgeons.
To assume the risk of a bad hammer strike here. Okay, if you can do it gently, it's not necessary. Okay, so that's this part. Let's go to the cotton. Now in the cotton we can try to impact, just to see. Okay, here is more easy because anatomically there is the extensor hallucis longus, and you have to find the joints, okay, and make an incision. I prefer to do the incision a little bit posterior medial, okay, because it's easier to go in, and because the design of the measurer and the wedge is to put, as you can see, have different shape in this way, is to put from medial to lateral, and in this way it was wrong. Okay, so make this. I don't know if you can see. Okay, this is the idea. Let's go this. We are going to make the incision a little bit longer than normal, just to see. Okay, so put the retractors here. One, okay. Okay, here we have a joint. Can you see that in the screen? Okay. I'm taking out tissues just to show you some trick in about the shape of the wedge and where to put the distractor here. Okay, here we are. Okay. Here.
To do hallux valgus as well, we'll go through.
Yeah. For lapidus. Okay, here we have more or less the anatomy. Here is the first tarsometatarsal joint. Okay. Here is the naviculocuneiform joint, and here in this lateral part you can see the shape of the wedge is bigger here in the distal part than here. Okay, so try to do the osteotomy just in the curve, okay, where it's a little bit bigger because you have more space. Okay, don't do it like here, that is very narrow, but here, not too distal to avoid problems in the first tarsometatarsal, but here more or less. Okay, and a little bit from medial to lateral, because this way you are going to preserve the intercuneiform joint. Okay, a little bit from medial to lateral. Okay, This is not easy with the shovel, but it's possible. Let's go. In this case, it's not necessary to break the plantar cortex. Here in the Evans, I think that is better, but here is not. And you can test with your osteotome if it's enough, if you can open it. Okay, it begins to open. Okay, so that's good. Maybe let's go to use the osteotome.
Then you can do advanced. So I never did those.
Okay, now it's good. So let's go to use the distractor here. Okay, here the distractor is the same reason than before. You can put here, that is what you first want to do, but it's better to go here, because then you are going to have all the field free to put your weights from medial to lateral. Okay, and there is another reason. All the problems to open this part are for the connection with the second cuneiform. So if you distract from this part, from the lateral part, you are going to distract in the tension band. So you are going to make all the effort where it is needed. More or less here. Okay. Extractor there. Okay. So now it's the same. You are going to open a little bit to release tissues. Okay, open and close, open and close. And when you feel that it's free, take care with the kiss and wire. Okay, the idea is to open and see that the first metatarsal goes down the amount of correction that you want to do. Okay, and then you can maintain the correction. Take your phantomas, make the measure. You can put here. Okay, and you can see if it's enough correction. Okay, in this case maybe is this. You have the measure here, 15, 5.5. So then you choose your wedge and put it on.
Oh, sorry.
Put it weight bearing on the plate to see exactly.
Yeah, with something like that, you can see that your first metatarsal arrived to the correct position.
Yeah, or you see.
Is this? No.
Don't need the flatfoot experience. Flatfoot experience.
Oh, you can see it. You can see it. And we have a plate. It's good.
Okay, so look, it's not that way. It's that way. Okay.
One more time.
It's not that way. It's that. So you can put from medial to lateral. Okay. So you are going to open it a little bit. You are going to put it. You are going to put a mosquito clamp here as before. And now we are going to close before put it in place, just to use the hammer. Okay. Just to make the demo. Okay. It is not in the surface, but you can try. It's not easy because there is a lot of friction. But you can put it down. Okay. Okay, now it's in place. Okay, you can see that it's in the surface, so that's enough. Okay, and again, it is not going to move anymore. Okay, you need a lot of strength to take it out if you don't open. Okay?
Is it really important to flush the implant with the dorsal surface? Because if you go down, then you're causing a distraction of the pyramid.
Yeah. There are different depths of the wedges. My advice is to use the shorter one, always.
I mean, it's,
But,
the
okay.
medial canopy is very long ball. Like, it's very long. I wouldn't worry much. I wouldn't worry much.
It's very, very long.
So you can if you put a bit lower down, if you use the short one, it doesn't matter.
If it's a bigger foot, you can use the longer
The long
one.
one, you can push it in.
Usually with this is enough, okay? To maintain the wedge correction, as you say.
Questions? How can we start?
Okay, so it's your turn.